Welcome to the BP2 Health podcast of Between Two Ferns.
It's actually the reverse Mullet healthcare podcast from BP2 Health. Today, we're talking about the power of healthcare analytics. But first, who are we and why are we here? And why did we name this Between Two Ferns?
Oh, because there are actually two areca palms.
They are areca palms.
Nice.
They are areca palms.
Why do we call it the
Florida.
reverse Mullet healthcare podcast?
We do because we want to be relevant, informative, and creative, but we also want to be entertaining and have fun. So it's party in the front and business in the back, like a mullet, only reversed between two ferns.
I'm Ellen Brown.
I'm Justin Paletti.
And I'm Dave Pavlik. We are passionate, innovative, and collaborative, and we are committed to solving our industry's most important issues together with our clients. We have a combined 90 years of experience.
Very old.
Yes, but we were talking last night about legacy, so I guess that does make us old.
That's not untrue.
That's true. In each episode, we're going to dig into a hot healthcare topic and dig into each other a little bit.
And I just ask that you be gentle on me.
We will.
But you never will.
Still trying to figure that
I know,
out.
right? So how's everybody doing? I'm still full from dinner last night.
Where did we go?
Well, it was a recommendation from one of our clients who isn't in Tampa anymore, but used to live in Tampa, and said you have to go to Berns Steakhouse.
AKA
The Haunted
Mansion in Disney.
It was literally walked in, and I looked up to see if the ceiling was going to rise, and like
Dancing
the thing
ghosts.
was going to like drop out of the ceiling.
Yeah, dancing ghosts everywhere.
The place is amazing. If you're ever in Tampa, you got to check it out. I mean, same. I walked in there and thought it was a haunted mansion, but as we got more into it, it's like
Al Capone's vault.
Yeah.
You're just one room after another.
Right.
Winding in through. It's super super neat.
so it used to be a mall. I think he said it used to be a mall.
He said
right?
it was an old 1960s, I think, strip mall.
Yeah,
And
they kept buying.
he opened up a restaurant in one of the shops, small kitchen, and then over time he kept buying up all the other stores, and now this whole mall is a restaurant.
Yeah, it doesn't look anything like a mall. Like you would never know it. But the coolest part, my favorite part was that there's a dessert room.
A dessert.
Well,
room.
the meal, your initial meal is only the first part of the experience,
Yeah,
right? You've got, they have a whole aspect where they take you on a tour, assuming, and to Ellen's point, we went for dessert afterwards upstairs, but they take you through the whole restaurant. Now, I was super impressed by the number of people that they have, first of all, working there in coordination.
150 people working in the kitchen.
Yeah, it was crazy. But they worked their way up, progressively.
It's like a tie thing. He was
It
like,
is, yeah.
It takes, what do you say, 4 years to get to the gray tie.
Yeah, and then
We're all walking through, and the waiters are like, trying to dodge
you.
us
Yeah,
with their
yeah.
trays. And
So it was really, there was a lot of energy there, and then the wine room is just like, it's hard to explain.
Well, there was a wine encyclopedia, so we knew that the wine room had to be something. But
wine-
it was like
I
something
think that
I've
he said that
never
it's
seen.
the largest private wine collection in the world.
He
They
did.
had about 25,000 bottles of wine, but that was only 10% of the collection.
And then an 1845 bottle that cost
49,000.
$49,000, or was it $45,000?
I guess
he
they're-
said out the door served $60,000 with gratuity.
Well, needless to say, we didn't.
I will never open that.
Yeah,
but
no.
It was unbelievable. They had me at dessert room.
Yeah.
I mean, I can't even going upstairs and then having just an entire dessert experience.
Yeah,
And then
no.
Ellen ordered 3 desserts that just
Well,
sat
there
there.
were 4 seats at our table, so I had to order desserts for the empty seat.
Desserts are like Ellen's wearables.
You can't have enough dessert.
Her
in
eyes
life.
light up. You could see them.
Yeah.
Like, all
It
right.
is. I think it is 75% of the reason why I run. No, it's probably 15%. But to be able to eat things like that, I just Okay, so before we jump in, I actually have something for you guys, a surprise for you.
More surprises.
Another one?
I have so many. I'm full of surprises today. Yes, but you have to close your eyes.
Again?
This is
Well,
a
for
really
those who
good
didn't see the
surprise.
buttons for the last episode, which you see right here, that was the
I
first
brought
surprise.
the buttons.
There's more?
So excited! I
All
brought
right,
the buttons.
I
Yes,
close our eyes
you-
again.
You really have to close your eyes.
All right.
Okay.
I'm not looking. We don't like dead airspace on the
Don't look
podcast.
yet.
Yeah, it's not good listening.
Right, gotta keep talking.
Feeling something squishy.
Okay, open your eyes.
All right, that's got to stay on the whole episode. now.
That's a reverse mullet.
You know that has to stay on the whole episode.
I'm so proud of myself.
Yeah.
Does it look good with the headphones though?
Yeah,
Yeah,
it looks
I
let's-
great.
just tested.
Let me see. Look at me. Party in the front.
It's a total party in the front, and it's business in the back.
It's not entirely business in the. Yeah, no, I like
It is
it.
business in the back.
That works
Yeah.
for you.
Okay.
You
No,
should wear
So
that.
I'm gonna wear it
Look a
today.
little bit like.
Looks a little Pat Benatar.
It does look a little
Oh,
bit.
I was going to say
Benatar.
Elvira.
Well, it is Halloween
or
almost. so.
Wednesday.
Yeah, it's like an orange and black thing. Okay.
All right, let's get into
I'm
this.
Good.
Let's get into
Maybe
this.
I'll
that,
make
that
you
is
laugh.
outstanding.
Thank you.
That
Okay.
is
That's
hilarious.
good.
That is
All
great.
right. Okay.
Now I guess
Oh,
Justin,
before we jump
Justin
in-
and I need to get
Okay,
get
but
our own too.
I don't know. You have to surprise me, but okay. Before we jump in, a shout out to our sponsor today and our friends over at Creative Health Advisory. We're pretty excited for them because they were instrumental in getting the deal between Walgreens and Pearl Health across the finish line, which is no small feat.
Creative Health Advisors is a healthcare-focused advisory firm focusing on investments and growth around value-based care delivery through primary care. They believe, like we do, that a shift away from transactional fee-for-service care arrangements aligns patient experience, patient outcomes, and clinicians' quality of life with financial performance. Creative Health Advisors serves both independent physicians and healthcare investors in developing growth strategies, physician practice valuation, brokerage services, and M&A process development. You can find them at creativehealthadvisors.com.
Yes.
Like those guys.
So what are we gonna? Love those guys. So
Yeah.
what are we gonna talk about today, Dave?
Talking about healthcare analytics. No matter who you are, Justin's grabbing the boring button
I'm gonna
already.
take. Oh, I get a button today.
Hey, listen. all right.
This is going to be really quick. There's going to be a real quick trigger on this.
I'm going to say this. No matter who you are or what role you have in the healthcare industry, analytics drives a lot of what you do, right? It can be used to improve patient care, reduce costs, make the healthcare system more efficient. The bottom line is useful and actionable data is critical to performance in any healthcare organization.
Even more so if you're a provider doing VBC or risk contracts.
Yeah, that's a big obvious
If
thing.
you don't have it, if you don't have analytics and you're doing that, it's a complete shot in the dark.
Yeah.
Well, a lot of times you're relying on your own internal stuff that, hey, you
gotta have
we'll
something.
refurbish this. You know,
You got to have something though. Not everybody can afford the big fancy
True.
platform. So
Like my hair.
like
I'm having fun looking through. Like there's like a look through the party.
nice. So
rock star.
what does analytics do for you? Anyone?
Oh, me,
Bueller?
me. I know one.
Yeah.
All right, let's hear it.
I wasn't ever that kid in class or anything. Predictive modeling, so predicting patient risk. It's not my favorite, but it's one.
So what does that even mean, though?
This is the one you hear about most of the time when it kind of goes in tandem. Kind of goes in tandem with population health. Whenever you talk about population health, right, you're talking about predictive modeling. Predictive modeling, and depending on which platform you use, it can do a lot of things, but it can assess future risk of patient population, right? Risk stratification, right? It identifies patients that are potentially going to develop certain diseases or certain complications. It's used to intervene early and prevent problems from occurring, right? It can be used to identify care management candidates. So you're looking at this stratification of risk of your patient population. Some of them are going to be, we got an intervention right away. Some of them are going to be rising risk, right? We got to pay attention to these and maybe get them into a care management program right away so they don't reach that upper level of immediate intervention. There are, I know the top 3 companies that have come up with, because this isn't something like the average Joe can take a bunch of data and figure out what the risk stratification is of their patient
Well, I
population.
know one of them is Hopkins because
Yes.
when we were working with them on that one project, I remember we actually worked with the team
Yep.
that developed their ACG, and
Yep.
it was crazy to me that they were the people that were actually driving that whole, and it is an industry recognized and utilized solution for risk stratification.
Yeah.
I
So
asked
how
too
are
many
you applying
questions.
that? No, so I guess going back to like your earlier kind of examples, how are organizations like applying this? Meaning like, hey, you have this information. How are we agreeing how we're going to act on it?
Well, right. It kind of depends. So ACG that she mentioned is one of the top 3. adjusted clinical groups, but there's also CCI, which is the Charlson Comorbidity Index. Say that fast 3 times.
No, I won't.
And then, of course,
dishcloth is more fun to say fast.
and of course, the HCCs, which is most commonly.
Well, that's
known
what we
throughout
all know,
Medicare.
right? I mean, that's what drives risk score under Medicare.
But how do people agree upon it? So I think they're kind of probably 2, well, maybe 3 categories of providers. One, they invest in a platform a population health platform, right?
Yep.
And it will include probably one of these 3, ACG, HCC, or CCI algorithms in the platform itself, so they don't have to try to figure it out themselves. There's more than 3. These are the top 3, but it's going to have something built in, right? And I suspect that while they're evaluating the different systems that they might want to purchase, they make that decision along the way. Maybe they believe ACG is better, maybe they believe CCI is better, and they pick a platform that is affordable. The second camp is those that they don't want to invest in something big like that. They're relying on data that they're getting from payers, their own internal data, and they have teams of people that can
I'd be really interested to know, when you were looking this up, I doubt you did, but you didn't see anything about, was there any comparative data around using one of these models versus just doing it yourself?
I did not, and I can't, and knowing how complex these things are, I can't imagine how somebody could just take data and come up with this themselves. I mean, all of these organizations did many, many, many trials to assess the accuracy of what they were doing, and years and years, and all kinds of high-tech, smart people.
Big data.
Right?
Big data.
Yeah, and so, like, take us, for example. So we
Machine learning.
We take data from people all the time, and come up with models and solve problems for them. I don't know how I would even start to tackle a big thing like risk stratification. Right? There's too many millions of data points that you have to deal with. And I think the third category is doing nothing. Right? And unfortunately, there are some that just either can't afford to. They can't buy a platform. Can't buy a platform. Some of them are really expensive. They don't have to be. There are some that are quite affordable, or they just don't want to.
Well, I think
to me, the biggest challenge is getting people on board and which direction you're going to row with the data, right? So you've got actionable information, but you've got a team of people who all have different opinions on the value of that that information, and whether or not you should be deploy certain resources to improve certain outcomes, or you basically say, hey, that's not that big a deal, right? Like, to me, the debate internally is how do you get the folks aligned on the vision of where you're going to go to have to use it.
I was thinking about this before we did this episode when we were prepping for it, and I go back to the poor physicians and the nurse practitioners and the nurses in the room that have to pay attention to this stuff. Like, it's to me, this is where we talked in a previous episode about administrative burden, and this I think it's important. I'm not saying we don't need to do it; we have to do it, but it's just
it's typical characters in the room that are you've got your physician leadership, you've got other clinical leadership, RN leadership, care management.
If you're lucky. A lot of organizations don't have sufficient
right. That's what I was going to say.
management.
Sometimes they're just so busy taking care of patients, they don't have somebody back there churning through data to try to figure out.
But even when you do, you've got those two, right? And then you've got somebody off to the side also who's pulling the data off the systems that we're talking about. And to me, it's like, all right, well, who's the one, or where are the people that are kind of aligning to get everybody together in which direction should go? Because you can spend a lot of time just debating and getting nowhere.
So let's say we were using risk stratification. What does it lead to?
Well,
why are we doing it?
So if you're at risk for Medicare Advantage, as an example, right? Like, why aren't you? You're using that to help manage your population, right? On the highest risk patients, right?
Leads to better outcomes, right?
So a lot of it goes to which programs you're participating in, right? That kind of line was back to the value-based care discussion. And
what are the performance metrics?
Right, exactly.
You
What's the compelling,
KPIs.
right? What's the reason why that we're doing this, and then what are the actions that?
So we go back to the triple aim. You've got right, but the big buckets are outcomes and costs.
Well, it's what Justin's first comment after I introduced the topic was especially important if you're in any of these kind of risk agreements, right? Risk arrangements, anything value based.
No, it isn't something that's optional, right? It is. You have to find a solution to it, whether it be homegrown or external. But the third category, which you both talked about, of doing nothing, isn't an option in those. No, in those.
No,
situations.
if you're in a any kind of risk arrangement and you're doing nothing, it's pure luck if you perform up to the to the standards.
So it also leads to reduced costs, and so I'll throw out a statistic. No definition. But I have a statistic. So in 2022, healthcare spending accounted for almost 20% of the GDP.
Yeah.
So I'd say there's an issue there, and it's just rising exponentially.
Yeah, but I'll add to that too. So it's about, if I remember correctly, it's about $14,000 per capita in the United States for healthcare.
Spend
$14,000 per capita. The next closest country is $8,000.
Yeah.
And it's Germany. And then it just goes down from there. First world countries, 8,000, 7,000, 5,000, 4,000.
I'm going to fact check you at the end of this.
You can fact check me. We're spending 14.
I love all these like statistics though. Like on a podcast, you can have so much fun with statistics because it's just the three of us talking. So everyone listening can have this like massive level of skepticism of, well, where did that statistic come from?
Yeah, and you can real-time fact check.
We fact checked each other.
Yeah. Well, if you find the fact, okay, so that's the thing, right? If you find the fact on the interwebs, it's a fact, right?
Yes.
No, I'm not fine. I am looking for
especially if it comes from Wikipedia.
Yeah, I do try to ignore. There's Investopia. When I looked up, the previous thing we talked about.
Investopedia, right?
Oh, yeah. Did I say it wrong?
Investopia.
I think
All right, that's pretty funny. All right.
Is it?
Investopia. It's Investopedia, right? And Wikipedia.
Hotel?
Investopedia? I don't know.
We could go down this whole thing.
All right.
Yeah.
All right. So bottom line though, it's outcomes and cost is why. I think that's it. When we talk about analytics, we have to talk about it because it's critical, but it's to mitigate risk for the organization.
Reduce cost.
And then it's to reduce cost if you're taking risk. And then it's also to improve outcomes. I mean, why are we doing? Because so many people, they're like, well, I don't see the value prop, so I'm not going to do it.
An individual practice.
Correct, or an organization or an enterprise. It's right. So to me, it's a fundamental.
That's
of
because
doing
they're living
business.
in the fee-for-service world.
The whole flipping industry.
Right. And we talked about this on the Change episode too, but so the bottom line is, and the big question is, how can we use analytics to reduce costs but not sacrifice quality of care?
I don't know. This makes me.
Well, this presumes that you're adequately being compensated, right?
Okay.
When we're saying reducing costs, right? Mm-hmm. There's another component, which is really understanding where you are within the marketplace versus your competition. And you'd be surprised how many people struggle with coming up with that baseline of information.
Yeah, we do that all the time for clients.
Right? And then you realize, hey, wait a minute, comparatively speaking, I'm losing money over here or over here, but how do I get myself to a point where I'm being adequately compensated? And I'm saying this like, if you look at behavioral health, for the longest time has been way underpaid. Way underpaid.
Okay, let me make sure I understand what you're saying. So,
unpack that for me.
Yeah,
please.
let me unpack.
I like that button.
But
I'm going to do it one more time. Okay, fine.
So, practices or organizations might see these savings opportunities to do extra things with analytics, invest in people to do this stuff, but they might be reluctant if they don't feel like they're being adequately reimbursed by the payers, or
that should be first, right? In order to, when I'm saying that,
because why am I going to spend more money to save them money?
Okay,
you're not paying me well.
Yes,
you're not paying me correct. You're not competitively, we should say.
Right,
and because the provider can always say, if you're not paying me enough, I'm not going to deal with you. But
we know for a fact that there are components within the system that are very much underfunded, right? When it comes to compensation,
Absolutely.
right? So if I'm
think
looking at all
primary
this
care
from an
physicians
analytics,
don't get paid enough.
well, depending upon what health system you're associated with, they could be,
I know.
you know,
In general,
way
though.
overcompensated.
Okay, fine.
You know.
That was a gross generalization.
What I'm saying is
Forgiven.
Thank you. I can't keep myself serious with this wig on.
analytics.
Very hot too.
Using that to really understand what your baseline is, as you know, as a jumping off point, to before you start, you know, looking to reduce costs further, that you need to really understand where you are, right, on the map.
and the a lot of times payer fee schedules are like this mysterious, you know, it's like shrouded in secrecy, right?
Mm-hmm.
It's
It's
hard.
like the Illuminati.
Yeah,
And we have to do that a lot for clients because, again, we talked about different platforms that folks might use, but, you know, comparing a fee schedule from one payer to the next is not really something that comes into these pop health
Right.
platforms, right? That's more of a do-it-yourself type of thing, right?
Well, there's no data transparency across the industry.
Yeah,
Have you ever tried to call a doctor's office to ask how much a procedure is going to be before you do it? Like, what's going to be?
Well, who's your insurance company? That's the first question, right?
Yeah, but you tell. Well, actually, no. They'll
then you
just
have an
say,
online tool that tells you
Right.
something, but it's, you know,
They'll say we can't tell you that until you have the
Right.
procedure
Yeah, okay.
and we get the claim processed. I mean, in what world is that? Is that okay? I go to the auto body place and the guy's like, or the auto repair place, and I'm sorry, I can't until I've done whatever to your vehicle. If you've ever tried to call a doctor's office, have you ever tried to call a doctor's office, Dave, and ask them to give you a quote before
No.
you have something done?
I never have.
Yeah, so I've done this, and it's a joke. I mean, they literally say to you, it doesn't even matter what insurance you have. They just say to you, I'm sorry, I can't, you have to have the procedure. We file the claim, and then you find out. I mean, if I go to the auto repair shop to have my car fixed, I don't go in and they say, it could be $25 or it could be $5,000, and we won't know until
Until we do it.
it's because too many people are not paying, meaning like they have a copay, so it doesn't matter, right?
Well, no,
What
it's also
high
because they
deductible
don't
plans,
want
it's
to tell
different.
me. They don't want to tell me because if I have this insurance or that, it's like they're like giving away the secret sauce of how much they get reimbursed.
Yeah,
And that's why it's hard. It's what we were talking about with trying to figure out if you're paid appropriately or competitively. The practices or the organizations, the healthcare organizations have to rely on data from their own, accounting system.
Yep.
And also from the payers, and they have to somehow meld that all together to try to figure out how am I being compensated and what's the baseline I should look at.
right.
Yep.
To see if it's fair. Most folks use a percentage of Medicare as a baseline, but it's not always that simple.
No.
So we've talked about risk stratification and analytics, and we've talked about the need for modeling. Well, I would say tracking for value-based contracts, right? If you're in VBC, you absolutely need analytics to be able to track your performance on that. I also think you need it to model out payer reimbursement outside of just VBC. You need to be able to understand what all that reimbursement. I mean, we have a client right now that we're in the middle of doing it for a bunch of different payers, trying to help them understand what
Where
each
they
of
stand
these
relative to
where
each
they
other,
right,
yeah.
and then just all these different scenarios that you have to plan for. And then I guess I would ask you, Dave. What do you think some of the trends are in the industry with analytics right now?
Well,
Do we get to talk about Twiggy?
you can, because everywhere in all of these topics, there's AI is embedded in the discussion somehow, right?
Cyborg. This wig actually could be kind of cyborg-esque.
Exactly. But I just
I thought of
organizations-
Madonna with Vogue.
I feel like organizations really need to look at this if they're not investing in it, and continue to focus on making investments into some kind of an analytical platform or folks to be able to run this data for them, because the trends that I see that are going to affect them are things like an increase in the use of artificial intelligence or machine learning. So there's more and more analytics
Tools.
capabilities and tools coming into the picture, right?
Interesting.
To analyze the healthcare landscape, right? So, it's also real world data. the rise of real-world data. You know what that is, Justin?
Real-world data is data that is collected outside of traditional clinical trials, such as data from electronic health records, EHRs, wearable devices, Ellen's favorite, and social media. I knew that right off the top of my head.
Yeah, you read that.
That was outstanding. Anybody listening could just hear you.
But
Like the radio voice came on and you were like, I am now going to read my talking point.
But it kind of tracks back to a conversation on an earlier episode where Ellen was talking about the Internet of Things, right?
Yeah.
Real world data.
It's aggregating. And this is the problem. There is no solution around aggregating data. There is no solution about interoperability. All this stuff is like a huge challenge, but I would argue that analytics is what starts to bring these disparate sources, these different data sets together in one place.
Yep.
I mean, which is part of why people avoid it, because it's really difficult and it's really expensive. And then I would say, again, I talked about this before, but it is one of my absolute favorite topics, which is analytics platforms that allow providers to track their performance under these VBC arrangements. Because I feel bad, I really do have and it's not the world's tiniest violin, like, you know, that whole thing. It's not the world's, I really do have a tremendous amount of empathy for clinicians, because they really do just want to provide good health care. They really do. And we've put all this stuff on them that they have to do. And then you throw analytics in there. And the interesting thing is, I feel like what we've seen is that is one place where if they get the report and they can see their performance compared to others, as long as there's trust and they feel like it's credible, it is a place of true engagement. Because they're like, okay, you're giving me something real and tangible that I can see, that shows me how I'm performing, you know, around my peers.
Yep, agreed 100%. And another trend is believe it or not, there is a more recognized importance of data
He's
sharing.
got his hand on a button.
Oh boy. There's a more, seriously, it's more recognized in the industry now. Providers are increasingly sharing their data with other stakeholders like pharmaceutical companies and research institutions and payers. And so it's enabling new and innovative ways to use the data and to improve the healthcare.
Since I don't want Justin to hit the boring button.
Yeah, how are we rounding this out?
It's you, Dave. Bring it home.
Well, it's hard to just wrap it up into a couple of sentences, because it's an evolving field, right?
You can do it. I have faith.
There are new developments on the horizon. Okay, what I'm most excited about is the rise of artificial intelligence. That's one of them. I know, it's being used to develop new healthcare tools, right? That can help us solve even more complex problems. So we have these population health tools that are doing it. Population health, risk stratification, all that, but AI is going to improve upon that. I still think it's a long way out, and I still think you can't replace the physicians on a lot of this stuff, if not most stuff. But at a minimum, there will be better predictive modeling.
All right, so how is that actually happening? When I say that, Chat GPT and these other things, like what are the actual tools?
It's more about big data, right? It's more about artificial learning, the machine learning with
mining through the data.
Let me ask you a question. Yeah, do you know how many rows of data Excel can hold?
No.
It's a million. It's about 1 million. It used to be much less than that.
So that's not big data.
No, it's about 1 million rows of data, but also 16,000 columns. That sounds huge, right? Big data and what a machine can learn from big data is we're talking about billions of rows or trillions of rows. So these tools that are doing the population health and the risk stratification and all that is not doing it on that scale. It's doing it on smaller populations. Therefore, there's less data, less.
And you're saying the AI brings.
So AI is like this big alien that can
Yes, it's not like Twiggy.
No, it's an alien. It's the movie.
It is. It's like the big thing. But we have to wrap this up. We can't keep going. We have to have another episode on this.
Yeah. Well, the other thing that I see, in the future is just the increase. You talk Ellen's favorite subject, the wearables, right? Those things are going to be
new and better data sources.
They're going to perfect that in ways that we're only scratching the surface on right now.
We're
but it's moving really, really fast.
We're going to help bring it in.
So I would close out by saying to anybody who's in that bucket of, we're not going to really do anything or we can't afford to find a way to make it happen. You got to make it happen in order to be successful.
I agree. All right. Well, thanks again. I'm Ellen Brown.
I'm Dave Pavlik.
I'm Justin Politi.
We are the partners at BP2 Health, your best chance for real change.
As you can tell, we could talk about healthcare all day.
Drop us a line through our website at bp2health.com. Reverse Mullet podcast is produced by Kim Rittberg and Emily Newman with Henry Street Media.